Good day, doctors. This is the continuation of our series of lectures on trematodes. For today, we will be discussing about the blood flukes. Trematodes can be classified based on their habitats in the human body. Those whose adult stages are found in the branches of the portal vein are referred to as the blood flukes. And these are our blood flukes, and they are all under the Schistosoma species. We have the Schistosoma japonicum, Schistosoma mansoni, and Schistosoma hematobium. At this point, we will be discussing their common names. Let's start with Schistosoma mansoni. It's easy to memorize its common name because the common name is derived from the species name of the worm, Manson's blood fluke. And then, we will be discussing Schistosoma hematobium. The common name for this worm is vesical blood fluke. The word vesical would refer to the urinary bladder because the adult stage of this Schistosoma hematobium is found in the vesical venous plexuses of the urinary bladder. Schistosoma japonicum is also known as the oriental blood fluke. Shown in the photo are the male and female worms of the Schistosoma species. The smaller and darker worm is the female, and it is situated in the gynecophoral canal of the male worm. Since the male worms have slits in the middle part of their body, we call it as the gynecophoral canal. These worms were named Schistosoma because the word schisto in Greek would mean split. The adult stages of our blood flukes are found on the different branches of the portal veins. The adult stage of Schistosoma japonicum is found on the superior mesenteric vein, and this is the branch of the portal vein that drains the small intestine. Small Japanese, small intestine japonicum. Schistosoma mansoni adults are found in the inferior mesenteric vein, the branch of the portal vein that drains the large intestine, large intestine mansoni. As I have mentioned a while ago, the adult stages of Schistosoma hematobium are found in the vesical venous plexuses. So, expect that the eggs of Schistosoma hematobium are released from the human body through the urine, while the ova or eggs of Schistosoma japonicum and Schistosoma mansoni can be found in the stool. I hope at this point you can still remember the general characteristics of trematodes and the exemptions, especially the ones related to Schistosoma. All are dorso-ventrally flattened except for Schistosoma. All have operculated ova except for Schistosoma. All have second intermediate host. All have the metacercaria as the infective stage. All are acquired through eating raw second intermediate host. All have the rhidia stage except for Schistosoma. At this point, we will be discussing the life cycle of the Schistosoma species. Human hosts harbor the sexual or the adult stage of the parasite. Therefore, human hosts act as definitive host. And what will be discharged out from the body host are the ova of the Schistosoma species. These ova are embryonated upon discharge. Therefore, once they will come in contact with water, they will release now the ciliated stage, which is the miracidium. This miracidium will infect the snail host. Inside the body of the snail, the miracidium will lose its cilia and will become the mother sporocyst. This mother sporocyst will later divide to form or produce the daughter sporocyst. Please remember that Schistosoma species do not have the rhidia stage, and the daughter sporocyst will eventually give rise to the tailed stage, cercaria, and we classify the cercaria of Schistosoma species as Furcos-cercos. There is no second intermediate host in the life cycle of Schistosoma. Instead, the Cercaria will directly infect humans through skin penetration. So therefore, the infective stage of Schistosoma species is the Cercaria, and the mode of transmission is skin penetration. It's very important to take note that as soon as the meracidium will invade the body of the snail host, it will lose its ciliated surface and it will become the mother sporocyst at the point of entry. 8 days after the infection of the snail, the germ cells will bud off from the point of entry or the site of development, and the mother sporocyst now will give rise to the daughter sporocyst, which will later produce the Cercaria stage. Letter A is a mother sporocyst. This mother sporocyst will later give rise to letter B, which is the daughter sporocyst. Take a look at the daughter sporocyst. It is not provided with oral sucker and short intestine, just like what you see in a Rhedia stage. Instead, what you can only see in the daughter sporocyst are the growing or developing Cercaria inside it. And letter C is just showing us the emergence of the Cercaria stage from the daughter sporocyst. The only intermediate host in the life cycle of Schistosoma species is the snail. In the case of Schistosoma japonicum, it particularly infects the Oncomelania quadrasi snail. These are the different snail hosts of the 3 species of Schistosoma, and I want you to memorize their names by heart. So I'll give you 5 seconds to familiarize yourselves with the names of the snail hosts of the 3 species of Schistosoma. Timer starts now. The infective stage of Schistosoma is the Cercaria stage, and it is described to be Forcocercus because it has a forked tail. And this stage will emerge out from the infected snail. Do you know that an infected snail can produce 230 Cercariae from one meracidium? But if the snail is infected by multiple meracidium, the possible number of Cercariae that can be shed from that particular snail is up to 280. This stage of the parasite penetrates the skin of the susceptible human host. Take a look at the structures of the Cercaria. On its body, we have there oral sucker, a small ventral sucker, but I want to give importance to the glands that you can find on the body of the Cercaria. These glands will produce lytic enzymes which will enable the Cercaria to penetrate the human skin. Schistosoma adult worms are dioecious, meaning they have separate sexes. In the picture, you have there the larger male and the smaller female. And the smaller female is lodged on the gynecophoral canal of male. Just like the other trematodes, they also have the oral and ventral suckers for attachment. These photos will show us the presence of the oral sucker and ventral suckers on both the male and female worms. And please do appreciate that the female worms are smaller but longer than the male worms, and they are housed in the gynecophoral canal of the male worms. I hope you can still remember from the introduction to trematodes that these Schistosoma species have bifurcated intestine. But unlike with the inverted Y-shaped intestines of the other members of the trematode group, the intestines of the Schistosoma adult worms will reunite at the distal portion of the worms. So they have this portion that is portion in their intestine that is bifurcated, and they have this portion that is formed by the union of the bifurcated segments of the intestine. I hope you can remember from the part 1 of our discussion on trematodes that the testes of the male worms are found on their anterior end because their middle up to posterior ends are occupied by the gynecophoral canal. So as you can see in the picture of the male worm, you have there the oral sucker, you have there the ventral sucker, and behind the ventral sucker, you have there the rows of testes. In the case of female worms, they have their ovaries in their midline. These are the female and male worms of the Schistosoma species. The thinner and darker worm is the female. I want you to locate for its ovary. It is found in its center. And I also want you to take note that the posterior portion of the female worm is primarily occupied by its vitellaria. The Schistosoma adult worms also differ with regards to their appearance. Worm A is Schistosoma hematobium, worm B is Schistosoma mansoni, worm C is Schistosoma japonicum. Question: which among the adult worms look highly tuberculated? The answer is Schistosoma mansoni. While the adult stage of Schistosoma hematobium is finely tuberculated, while the adult stages of Schistosoma japonicum have smooth surfaces. Since the adult worms are found in the blood, they must have means on how to get nutrients for them to survive. These adult worms are known to ingest red blood cells, and they have this protease or hemoglobinase enzyme that will now break down the globin portion of hemoglobin. And these worms can also utilize the glucose molecules present in the blood. And according to some studies, that the nutrients are just basically absorbed through their surfaces or body walls. I have a question. The adult stages of Schistosoma species are found within blood vessels. And you know very well that inside these blood vessels we have the immune cells. We also have antibodies. So, how do you think these worms will protect themselves from the components of the immune system? There are several ways on how the Schistosoma adult worms can evade the immune responses. Number 1 is surface turnover. These worms are known to secrete the antigens present on their body surfaces or teguments so that the antibodies will attack these antigens at a distance away from the parasite. What a smart move, right? Then, some of them can also display antigen mimicry, meaning they will display antigens that look similar to the antigens of the human host. Therefore, they will be treated by the immune system as self and they will never be attacked. Others evade the immune responses by antigen disguised, meaning they will cover themselves with the host proteins so that they will be considered as self by the immune system. At this point, we will be describing the diagnostic stages of Schistosoma species, their ova. Let's start with the ova of Schistosoma mansoni. The ova of Schistosoma mansoni and Schistosoma hematobium are bigger than that of Schistosoma japonicum, and they appear to be longer than they are wider. What do I mean by that? For Schistosoma mansoni, its length can range from 114 to 180, and its width can range from 45 to 70. That's why it is longer than it is wider. The eggs of Schistosoma mansoni and hematobium are elongated in shape or pear-shaped. All trematodes have operculated ova except for Schistosoma. So expect that the ova of Schistosoma mansoni, Schistosoma hematobium, and Schistosoma japonicum are non-operculated. Now the question is, how will you know if the non-operculated ovum is that of Schistosoma mansoni? You have to look for that prominent lateral spine near the posterior end. And since the adult stage of Schistosoma mansoni is thriving in the inferior mesenteric vein, expect that this ovum or egg can be found in the stool. So the stool is the diagnostic specimen. Again, the ova of Schistosoma hematobium and Schistosoma mansoni are bigger than that of Schistosoma japonicum, and they appear to be longer than they are wider. And the size of the ova of Schistosoma hematobium is almost similar to that of Schistosoma mansoni. Again, this egg is non-operculated, and for you to identify it from the other ova of the two Schistosoma species, you have to look for that terminal spine. So, in Schistosoma mansoni, you have there a prominent lateral spine. In the ovum of Schistosoma hematobium, you have there terminal spine. And since the adult stage of Schistosoma hematobium is found in the vesical venous plexuses, expect that the eggs of this parasite will be seen in the urine sample. The ovum of Schistosoma japonicum is way smaller than that of the Schistosoma mansoni and Schistosoma hematobium. And the ovum of Schistosoma japonicum appears to be more rounded. Now, how will you know if the egg you're looking at is that of Schistosoma japonicum? Just look for a curved hook or small spine on the posterior end. And since the adult worm of Schistosoma japonicum is found in the superior mesenteric vein, expect that you will see these eggs in the stool sample. Let's try to identify these three ova. Let's start with the first picture. It has a prominent lateral spine. So therefore, this is the ovum of Schistosoma mansoni, and the diagnostic specimen is the stool. The egg in the center has a terminal spine, so therefore, that is from Schistosoma hematobium, and the diagnostic specimen is urine. While the egg on the lower part of the screen has a small knob or a curved hook on its lateral side. So most likely that is from Schistosoma japonicum, and the diagnostic specimen is stool. We will now be discussing the clinical manifestations and pathogenesis of schistosomiasis, or it's also popularly known as bilharziasis. The infective stage of Schistosoma species to humans is the Cercaria, and the Cercaria will infect humans via skin penetration. So expect that one of the clinical manifestations in schistosomiasis will involve the skin. And we will call the condition as cercarial dermatitis. And this one will start to manifest 12 hours after the skin was penetrated by the Cercaria stage. This is an example of the picture of cercarial dermatitis, but I want to emphasize something. Cercarial dermatitis will only be possible if the human host is infected by the cercarial stage of Schistosoma species that normally infect birds. But if the human host is infected by the cercaria of Schistosoma mansoni, Schistosoma hematobium, or Schistosoma japonicum, there's a less chance for that human host to develop cercarial dermatitis. This is a picture of cercarial dermatitis. Take note, this is caused by the cercaria stages of Schistosoma species that infect other animals, particularly birds. Take note, that the infective stage of Schistosoma species is the cercaria. Once inside the body, the cercaria will lose its tail and will become the schistosomule. Take note of this. After penetrating the skin, the cercarial stage will lose its tail and will become the schistosomule. Take a look at the cercaria in the picture. As soon as it has already invaded the tissue shown in the picture, it will actually lose its tail and it will become the schistosomule. Again, the infective stage to humans is the tailed stage cercaria. After penetrating the skin, the cercaria will lose its tail and will become the schistosomule. The schistosomule will be transported by the blood circulation towards the right side of the heart, and the right side of the heart will pump the blood along with the schistosomule towards the pulmonary circulation, and the blood from the lungs will be returned to the left side of the heart. And it is now the arteries that will bring the schistosomule to the liver. The schistosomules will penetrate the liver parenchyma so that they can gain access to the portal veins. And that is now where they will mature to form the adult stages. So, take note of the organs that can be possibly involved in the life cycle of schistosoma, especially if it is already inside the human body. You have there the involvement of the lungs, the liver, and the branches of the portal veins. You have learned a while ago that the schistosomules in the pulmonary circulation will be transported towards the left side of the heart, and it is the arterial system that will transport the schistosomules to the liver so that they can gain access towards the branches of the portal vein. But recent studies have proven that these schistosomules can penetrate through the lung tissue and escape into the pleural cavity so that they can gain access to the diaphragm and dig their way into the hepatic parenchyma or liver parenchyma so that they can invade the branches of the portal veins and will eventually become the adult stages. Schistosomule can be found in the pleural cavity on the second day of infection, and this will only prove that they can pierce through the lung tissue. And on the fourth day, they can be isolated from the diaphragm. And on the sixth day of infection, they can now be found in the hepatic tissue or the branches of the portal veins. And to prove that the result of the recent studies is true, there is the presence of superficial lung petechiae on the 4th to 6th day after the cercarial skin penetration, and this will only prove that schistosomules can really pierce through the lungs to escape into the pleural cavity, to invade the diaphragm, and to go directly to the liver, to go to the branches of the portal veins. Schistosoma species can also cause what we call Katayama syndrome, and this occurs 4 to 6 weeks after the cercarial skin penetration, and this one coincides with the migration of the schistosomule inside the body. Patients with Katayama syndrome would present with fever because there is infection. They would present with eosinophilia because there is parasitic infection. They will present with cough because of the migration of the schistosomule into the lung tissue. There would also be abdominal pain and hepatosplenomegaly because of the involvement of the liver in the migration of the schistosomule. Schistosomiasis can also have a chronic form, and this one usually results with the deposition of the parasites ova into the different tissues in the body. And since these ova are foreign and the immune system will try to eliminate them, And since they are hard to eliminate, then that would result now to the formation of granulomas. Granulomas tend to expand and they would replace normal cells or tissues, resulting to damage to the organ. Why do you think there would be deposition of the ova of these parasites in the different tissues in the body? Let's take a look at the adult worms. They are found in the lumen of the branches of the portal veins. Take a look at the adult worms pointed in the picture. They are situated in the lumen of the blood vessels. If the female worm will lay eggs, the eggs are discharged towards the terminal portion of the veins in the mucosa or submucosal layers of the intestine, and it will now be drained into the lumen and it will be passed out in the stool. In the case of Schistosoma hematobium, the egg will be released into the lumen of the urinary bladder and will be excreted in the urine. But the thing is, there is a circulating or flowing blood into the lumen of the intestine. There's a chance that some of the eggs might be carried by the circulating blood. And since this is a branch of the portal vein, the blood will now carry the eggs towards the liver. And from the liver, it can also be transported to other tissues in the body. Do you know, in some instances, eggs can also be deposited on the walls of the intestine or urinary bladder. So what will happen? There would be the production of granulomas there. With granuloma comes fibrosis. So if that area will become fibrotic, then there's no chance for the eggs to be released into the lumen of the intestine or lumen of the urinary bladder. So all of the eggs now will be carried by the flowing blood towards the portal vein, then into the liver, and maybe to other organs in the body. This is another picture of the adult schistosoma worm within the lumen of one of the branches of the portal vein. Take a look at the superior and inferior mesenteric veins. They are the branches of portal veins, and the blood within them could carry eggs that were laid by the female Schistosoma adult worms found in the small and large intestines, causing these eggs to be deposited in the liver, or maybe it will be transported by the hepatic vein towards the inferior vena cava, towards the right side of the heart, then into the lungs, to the left side of the heart, and to the other organs of the body. So these are now the clinical courses of schistosomiasis or bilharziasis. Number 1, it starts with incubation. This starts from the penetration of the skin by the cercaria up to the point that the schistosomule is migrating inside our body, up to the time that these schistosomules will mature to form the adult stages. So, what possible clinical manifestations can be seen in the patient at this particular point? There could be cercarial dermatitis. There could be Katayama syndrome. Then, incubation will be followed by period of early egg deposition and extrusion. Later on, if the eggs will be deposited in the tissues, then you will reach the third clinical course, and that is the period of tissue proliferation, such as what is seen in granulomas. If the eggs will become dislodged or deposited in the different tissues in the body, then they can initiate granuloma formation. With granuloma formation, there is tissue destruction. Again, the female adult worms will lay eggs. The eggs might be carried by the blood circulation into the portal vein, then into the liver, and to the other organs of the body. And the eggs, once deposited, will initiate granuloma formation. This is the normal appearance of the liver under the microscope. Should there be the presence of deposited ova of schistosoma there, you would appreciate that there would be formation of granulomas. And the granulomas will surround the deposited eggs in attempt to clear them. But the problem is this granuloma will expand, will become bigger in size, and they will replace the normal hepatocytes. And that will explain why chronic schistosomiasis will eventually lead to the fibrosis of the liver and liver cirrhosis. In the presence of liver cirrhosis and the fibrosis within the liver, there would be what we call portal hypertension. So there would be an increased resistance within the liver. That's why the blood in the portal vein will no longer be able to enter the liver. And you know what will happen? The blood in the portal vein will be regurgitated back to the branches of the portal vein. And these branches will dilate because of the build-up of blood. That's why they will develop varices. That's why in the picture, you can see in there that the varices can form at the distal portion of the esophagus and as well as the stomach because their venous drainage are part of the branches of the portal vein. With portal hypertension, there would be the formation of varices. This is the endoscopic view of a normal esophagus. This is how the esophagus would look like in the presence of esophageal varices. Do you know the problem with these varices? They have thin walls. So thin that there's a chance that they might rupture and cause acute blood loss. The ova of schistosoma can be deposited in the liver parenchyma, resulting to fibrosis and granuloma formation, which will eventually cause portal hypertension. And this portal hypertension can cause the formation of varices. Varices are life-threatening dilatations and swelling on the veins, particularly in the esophagus and the veins of the gastrointestinal tract organs. And these varices, since they are thin-walled, can just randomly become torn and bleed profusely. In some cases, the eggs are deposited along the intestinal wall. And this is commonly seen in infections caused by Schistosoma mansoni and Schistosoma japonicum. And I don't think I need to explain to you why. Now, the problem is the presence of the deposited eggs will trigger inflammation, granuloma formation, which will eventually cause some episodes of bleeding, diarrhea, and there would be formation of fibrosis along the colon, and in some cases, can even lead to obstruction. There are cases wherein the eggs will pass through the liver via the hepatic vein and it will be carried to the inferior vena cava, then to the right side of the heart. And there's a probability that these eggs will obstruct the blood vessels in the lungs. If these blood vessels are obstructed, then it would be hard now for the right side of the heart to pump the blood towards the lungs. And we call that as cor pulmonale, C-O-R-P-U-L-M-O-N-A-L-E. And the consequence would be right ventricular hypertrophy because the right ventricle will have to double its effort just to pump the blood towards the lungs for reoxygenation. The brain and the spinal cord can also be involved in schistosomiasis or bilharziasis. This happens when the eggs will pass through the liver, then will be brought towards the right side of the heart, then to the pulmonary circulation, then to the left side of the heart, only to be pumped out from the heart through the aorta, and they will be transported by the branches of the aorta towards the brain, and they will be deposited in there. and they will also initiate granuloma formation. And this one is now referred to as the cerebral schistosomiasis. And the clinical manifestation will depend on what portion of the brain where the eggs are deposited and where they are initiating the granuloma formation. Most of the time, the eggs that reach the brain are that of Schistosoma japonicum. Why? Because they are spherical in shape. So it would be easy for them to squeeze through the lumen of the blood vessels. Again, because the ova of Schistosoma japonicum are rounded and they are smaller than that of the Schistosoma hematobium and Schistosoma mansoni, they can reach the brain and cause cerebral schistosomiasis. But if the organ involved in the CNS is spinal cord, then there's a high chance that the ones involved are the other two Schistosoma species, the Schistosoma mansoni and Schistosoma hematobium. And the main reason is there's a chance that the ova of these two Schistosoma species might reach the what we call Batson plexuses. These Batson plexuses are valveless veins found along the vertebral column. And since they are valveless, they cannot prevent the transport or passage of eggs of Schistosoma mansoni and Schistosoma hematobium into the spinal cord. Shown in this picture are the Batson's vertebral plexuses. These veins are valveless. That's why it's easy for the eggs of Schistosoma mansoni and Schistosoma hematobium to be transported from the site where they are laid by the female adult worms towards the spinal cord and cause cerebral schistosomiasis. Let's talk about Schistosoma hematobium. The adult stages are found in the vesical venous plexuses. Once the female worms will lay eggs, some of the eggs are released into the lumen of the urinary bladder only to be released through the urine. But the thing is, there are instances wherein the eggs are deposited on the wall of the urinary bladder. And that can cause now damage, leading to chronic inflammation. And chronic inflammation will cause what we call squamous metaplasia. What's squamous metaplasia? The lining epithelium of the urinary bladder is transitional epithelium, and it is designed to allow the urinary bladder to expand whenever it is filled up with urine. But since there is constant damage, injury to the walls of the urinary bladder, the transitional epithelium will be replaced by stratified squamous epithelium. This is the picture of squamous metaplasia of the urinary bladder. On the left portion of the tissue, you can still find in there the normal transitional epithelium. But on the right side of the photo, it's very clear that the transitional epithelium is now replaced by stratified squamous epithelium. If not treated, the squamous metaplasia will progress to neoplasia or cancer. That's why Schistosoma hematobium is recognized as one of the causes of urinary bladder cancer. Before the discovery of cigarettes, Schistosoma hematobium is the number one cause of urinary bladder cancer. Today, cigarette smoking has already replaced it as number one. And Schistosoma hematobium is now the second leading cause of urinary bladder cancer. So how do we diagnose schistosomiasis or bilharziasis? Number one, we can perform circumoval precipitation test or just simply COPT, circumoval precipitation test. We will get serum from the patient. The main purpose is to determine whether the patient has antibodies against schistosoma, because if she or he does have antibodies, then it would mean that she has or he has the infection. The next thing that we will do is to add the serum of the patient to known eggs of Schistosoma. Then we will incubate the setup for 24 hours. If the patient's serum has antibodies, the antibodies will bind to the eggs and they will cause formation of precipitates or microprecipitates around the eggs. And the presence of these precipitates would tell us that the patient's serum has antibodies and the patient could be infected with Schistosoma. This is Schistosoma mansoni ovum. Then appreciate the precipitates that are formed on its surface, indicating that the serum we added to it has antibodies. Picture A is negative for antibodies. Picture B, since there is formation of microprecipitates, is positive for antibodies to Schistosoma. We can also perform rectal biopsy. In this procedure, we'll just get a small portion of the rectum and make a thin section of it, put it on a slide, and apply stain, and simply look for the presence of deposited ova. This is a picture of a rectal biopsy that is positive for the presence of deposited Schistosoma ova. We also have a skin test that is designed to diagnose schistosomiasis. Take a look at how the procedure is done. The antigen of Schistosoma, adult or cercaria, is introduced intradermally into the skin of the patient. We refer to the skin test as Fairley's skin test, and its principle is similar to the Mantoux skin test that we utilize to diagnose tuberculosis. So after introducing into the skin the antigen of either the adult or cercaria of Schistosoma, we need to check the site. Check it after 10, 15, or 20 minutes, and we need to check it after 24 hours. Should there be swelling on the site of the introduction of the antigen, that would indicate a positive result. As for the treatment, praziquantel is the drug of choice. And listed here on this slide are the means of preventing schistosomiasis. Number 1, proper human waste disposal so that we can disrupt the life cycle. Number 2, we need to control the number of the snail hosts. By what? Controlling their breeding sites. Number 2, remove shelters and shades by cutting off the vegetations because these snails are known to be active during nighttime or whenever they are in a place that is shaded from the sunlight. And you can also line the streams and canals with concretes. Health education and chemotherapy is the strategy that is adopted by community doctors and community medical professionals, especially in areas with high prevalence and high transmission of schistosoma. If you're going to treat those that have the infection, then you will lessen the transmission. And that ends my lecture on the blood flukes. Can you take a look at the egg of Schistosoma hematobium? Can you see that the miracidium is moving inside? Thank you very much for listening.